All right. Again, this is the second lecture about peripheral artery disease. Today we'll talk about chronic limb-threatening ischemia. You know, the term critical limb ischemia is old and fails to describe the full spectrum of patients who are evaluated and treated for limb-threatening ischemia in the current era. And the new term will be saying CLTI is a broader and more heterogeneous group of patients with varying degrees of ischemia that can often delay wound healing and increase amputation risk. And based on the new nomenclature, CLTI, there are patients who would be excluded from this definition, including patients who have venous ulcers or embolic ulcers or embolic ischemia or acute limb ischemia, traumatic ulcers, also autoimmune disease with vasculitis and neoplastic diseases. The old definition, critical limb ischemia, used to be defined as ischemic wrist pain with ankle pressure less than 40, and tissue necrosis with ankle pressure less than 60. And importantly, the old definition used to exclude patients who are diabetic. And so this definition has long been debated because it failed to capture a large portion of patients who are at risk of amputations from ischemia and diabetes at the same time. And the new definition is chronic limb-threatening ischemia, unlike critical limb ischemia. And the definition is objectively documented atherosclerosis, PAD, in association with either ischemic wrist pain or tissue loss. And when we talk about ischemic wrist pain, it's typically described as affecting the forefoot or the toes and is often worse with recumbency and better with dependency. It should be present more than 2 weeks and associated with abnormal hemodynamics. And I like to memorize these hemodynamics by the 30, 40, 50 rule, because these are a lot of numbers. And so the 30, 40, 50, so toe pressure less than 30 and transcutaneous partial pressure of oxygen less than 30, ankle brachial index less than 0.4, and ankle pressure less than 50. And at the same time, we have to have a flat or dampened or minimally pulsatile waveform on the pulse volume recordings. So now I need to also mention important things here is the pressure measurements should be correlated with the Doppler, because you have to keep in mind that ankle pressures and ankle brachial index are frequently falsely elevated because of these patients who have calcification or medial calcinosis of their vessels, and their ankle pressure or ABI might be higher than reality, especially patients who are diabetic with ESRD. And so for that reason, you have to do a combination of these hemodynamic testing. And so in patients with diabetes, ESRD, I think the best thing is to do toe waveform and systolic toe pressure, because the ankle pressure alone can be falsely high in these patients. What about tissue loss? This is the second part of the definition. Tissue loss related to CLTI includes gangrene of any part of the foot or non-healing ulceration present for at least 2 weeks. And it should be accompanied by evidence of PAD, not just any ulcer. You have to prove that patient has PAD, and this is what the Wi-Fi score was telling us. The second part of the Wi-Fi, the ischemia portion, you have to have at least grade 1, which I will talk about. And so This definition excludes, traumatic venous ulcers and neuropathic ulcers. And so CLTI is present if either ischemic rest pain or tissue loss with appropriate hemodynamic. Now, I'll mention quickly something called the angiosome principle. It's a 3-dimension anatomic block, including the skin, subcutaneous tissue, muscle, bone. And we're talking about a 3D block that is supplied by a certain vessel. And the reason we are talking about angiosome is some patients may have normal hemodynamics, looking at the foot as a whole, but they still have ulcer in a certain part of the foot. So they must have diminished local perfusion in only a small portion of that foot. And that's what we mean by angiosomal ischemia. Or sometimes patients have occlusions of the 3 infrapopliteal diseases, the vessels. So anterior tibial, posterior tibial, peroneal 3 of them are occluded. So then we start thinking, which one should we fix? Because a lot of times it's hard to fix all of these vessels. And so I think that's where angiosomal concept comes in hand, is you look at the area that has ulceration and what vessel supplies that area. This is an example of angiosomal ischemia. This patient has tissue loss to the tips of the first and second toes of the foot. And as you see here, he has 3 vessel disease. The posterior tibial is occluded completely and does not reconstitute in the foot. And the peroneal has also osteal disease. It has stenosis here. And the anterior tibial has multiple occlusions and then reconstitutes slightly here. And this is a peroneal. And so how would you approach this patient? I think, the digits have double supply from the anterior tibial, the posterior tibial. And so the posterior tibial is really hard to fix in this case because the vessel completely disappears here. But the anterior tibial, at least you might be able to try opening. But also sometimes if you can't open the anterior tibial, then you try to open the peroneal, because the peroneal might have collaterals to the foot. So that's a last resort you can do, is opening the peroneal if you can't open the anterior tibial. Going back to the Wi-Fi score, which we've talked about last time, there are 4 clinical stages. And this score correlates with the risk of major amputation and time to wound healing. The 3 scores is wound, and the wound is from 0 to 3, no wound or no ulcer. There is superficial ulcer, deep but limited to the foot, to the toes, and deep and extensive to the foot. And then the second is the ischemia. So in CLTI, Wi-Fi is used for any type of PAD, intermittent claudication, but in the CLTI in particular, you have to have a stage 3 ischemia, as we talked earlier. You have to have a toe pressure less than 30. You have to have an ABI less than 40. You have to have an ankle pressure less than 50. That's the 30, 40, 50 rule that I mentioned earlier. And then the third part of the Wi-Fi score is the foot infection. And again, from 0 to 3, no infection, mild, moderate infection with deep tissue involvement, and then the severe infection with systemic sepsis. And so the higher the score of the Wi-Fi, the higher the risk of amputation. The prevalence of CLTI, there's about 2 million patients with CLTI in the US. Half of these patients lose their limb at 1 year. 1/4, about 25% of patients die at 1 year. And so this is a very high mortality disease, and that's something patients need to know. And 25 patients would die in 1 year. And the amputations, major amputations, there's significant numbers performed in the US. There's a lot of money spent on this disease. This figure shows risk factors for PAD in in the high income and low income countries. The high income is red, low income is in blue. The risk factors, as you know, smoking, diabetes, hypertension, hyperlipidemia, and patients with diabetes are widely recognized as having a higher risk of amputation. Also, interestingly, you look at the BMI here. You know, the obesity and BMI is inconsistent, and many studies have talked about this, what they called obesity paradox. And we see it, and I'm sure you guys see it too, probably less, but with lower rates of PAD observed in patients with high BMI. And then the last thing I have to talk about is CKD. Patients in particular who have end-stage renal disease, they have really strong risk factor for PAD and also limb loss. And these patients, they mostly have distal diffuse disease and heavily calcified disease. These are important information to mention to your patients when you talk to them about CLTI. When someone comes in with foot ulcers, when someone comes in who are asymptomatic or have intermittent claudication, there is about 20% chance they will develop CLTI in 5 years. And so these patients have to know these information so that they can take it seriously. And that risk is even higher in patients who are diabetic. And around 50% of patients presenting with CLTI, they had no prior history of PAD. All of a sudden, they have CLTI, they have foot ulcers. And these patients are usually older males with history of renal failure, diabetes, and stuff like that. Rates of amputation is very high. The 5-year risk of amputation in Rutherford Class 6 is 67%. There's 67% if you have Rutherford Class 6, there's going to be amputation. Mortality is very high, and this is a different study than I mentioned earlier, but if you have Rutherford Class 6, the 4-year mortality is 60% if you have CLTI. The anatomic patterns of CLTI, and I think this is a very important figure that we need to understand well. CLTI is usually the result of multi-level disease. It's not an occlusion at a certain point only. There is multiple lesions at multiple levels, and you can also have parallel disease. You can have SFA disease, profunda disease at the same time. And below knee arteries typically become increasingly involved as the disease progress. And, however, femoral popliteal and infrapopliteal disease does not always progress in parallel. A lot of times, one bed will progress more than the other. A lot of times, the infrapopliteal will become worse than femoral popliteal, or the opposite. It really depends on the risk factor. In patients with CLTI and infrapopliteal disease, the posterior tibial artery tends to be the most diseased, and often with the peroneal artery is the least diseased. So that's something you will notice in CLTI patients. Posterior tibial is mostly involved. The peroneal artery is the least involved. And I'm just gonna try to mute everyone else. I think there's some type of echo coming from someone. Anyways, so going back to this important image, I think there are a number of specific factors that we have to look at. Women may be more prone to have femoral popliteal disease, while male they have iliac, and they have below knee disease. Same with diabetic patients and older patients. They will have below knee disease more than above knee disease. And the opposite for smokers and hyperlipidemia, they will have femoral popliteal and iliac disease more than below knee disease. And all patients presenting with symptoms of CLTI should undergo really detailed vascular assessment, in addition to, detailed history, knowing their risk factors, drug history, family history, and prior amputations, prior interventions. On examination, ischemic ulcerations and gangrene are mostly located on the toes or the forefoot, but other areas sometimes are involved, especially in diabetics, where the biomechanics are altered and there is neuropathy, and so sometimes you can have ulcers in areas that are known as load-bearing areas, such as the ankle, but mostly the toes and forefoot. So all patients with suspected CLTI should have detailed physical examination, palpation, and there's the other signs, coolness and dry skin, and loss of hair and dystrophic toenails. There's also the Berger sign, where there's pallor when you elevate the foot, and rubor when you lower the foot to the ground. And the capillary refill time will usually be more than 5 seconds. When you raise the foot, it's going to take more than 5 seconds for the pallor to go away, and these are some of the signs of CLTI. And so it's really important, when we examine these patients, that they have to be laying flat, not sitting on a chair with their leg hanging down, because we're going to miss some of these signs. The non-invasive hemodynamics, as we mentioned indirectly in the prior slides, the ankle pressure and ankle brachial index are the first things we're going to do in all of these patients with suspected CLTI. It's also important to look at the Doppler waveform, as mentioned before. That you have to make sure that the Doppler waveform is not dampened, it's not flat, if the ABI is normal. And if the ABI falls and the waveform becomes dampened, then you have to really consider CLTI, and you have to think about performing other non-invasive hemodynamic testing, such as the toe pressure or toe brachial index. And the toe pressure, what you do is you put a minimal cuff around the great toe, or the base of the great toe, and then you put in a continuous wave Doppler flow detector on the great toe, and then you deflate the cuff slowly until you detect the systolic toe pressure. And usually the toe pressure normally should be about 20 to 40 less than the ankle pressure. But we have to remember that the toe pressure is more sensitive than ankle pressure in diagnosing CLTI. Over the next slides, I will go over the imaging modalities we use in CLTI, and I'll talk briefly about advantages and disadvantages of each one. Duplex is usually the first modality we use, and in some healthcare systems, it's the only modality available. And that's why I think, particularly maybe in Yemen, it's important to learn and master duplex ultrasound. In the US, the technicians do the test, and we interpret the images after they transfer the images to us. But ultrasound is very detailed. It will just comment. I'll talk about it briefly here. It provides information on the anatomic location and the extent of the disease. As well, it will give us information about the flow volume and velocity. There may be difficulty in interpreting iliac disease because of the bowel gas, but you can detect that by when you do femoral ultrasound. You can look at the inflow waveform. In the infrapopliteal segments, it can be really challenging to do duplex ultrasound because these vessels are heavily calcified and diffusely diseased. So in general, ultrasound is inferior to the other modalities such as angiogram and CTA, but it offers many advantages. It's a non-invasive, cheaper, no contrast, no radiation. And the main disadvantage of ultrasound is it's time consuming, and also it can be really technical dependent, operator dependent, and it does not produce the whole arterial map of the lower limb. Also, you can't really tell if there are collaterals with duplex ultrasound easily. The second one is CTA. We use CTA heavily, and this is a patient that I did yet last night just to show you how I read CTAs. In recent years, CTA has advanced, and modern CTA gives us really high resolution and images and 3D images. CTA is very good with aortoiliac and femoral popliteal segments with very high sensitivity and specificity, almost 95, 99%. But the CTAs are not that good in infrapopliteal disease. And the main issue we face when reading infrapopliteal disease is blooming artifact in these calcified arteries. And the calcium deposits make lesions appear larger than they are, and that results in lower accuracy of the test, especially in CLTI patients who have a lot of infrapopliteal disease. Also, if you obtain the CT images too early or too late, you tend to see unfilled segments, and you think there is occlusion, but there's really no occlusion, but the images were taken too early or too late after the contrast washed out. And so CTA is primarily used to image aortoiliac and femoral popliteal, but less in the infrapopliteal disease. Also, you have to look at the axial segments, coronal segments. The most important is the axial segments. And sometimes I struggle when I receive these images, on WhatsApp, and I need to analyze them in details. And so it's really not possible to read a CT unless you have all the phases to be able to detect every single segment and make sure you're not missing anything. The next one is MRA. The good thing about MRA is it can produce images that are comparable to angiogram without the expense of radiation and contrast we use with angiogram. There are special techniques that are now used with MRI in cases of CLTI that makes below knee vessels look really clear. And contrast enhanced MRI using gadolinium is preferred because it has high, they call it noise ratio. The contrast to noise ratio is high and better spatial resolution. But MRIs also have limitations. They struggle visualizing calcified segments, and also if there is end-stage stenosis, MRI is not as good. Patients who have devices, pacemakers, ICD, then you have to make sure these devices are MRI compatible. There's more expensive. Patients don't like it because they get claustrophobic from the MRI. Also, if the GFR less than 30, then you're at risk of nephrogenic systemic fibrosis, although there are studies questioning that. Peripheral angiogram is the gold standard. The presence of the CTA, duplex, and MRI nowadays, we use angiogram less frequently for diagnosis, but it's still widely available. The complication rate is very low when you just do a diagnostic angiogram. And the good thing about angiogram, if you do a diagnostic, is sometimes you can intervene in the same setting if you find a single lesion that's easily fixable, or if you find a lot of lesions throughout the leg, femoropopliteal, infrapopliteal, and you think you're going to have to fix it endovascularly, then sometimes while you're doing a diagnostic angiogram, you can fix a femoropopliteal segment, for example, and then you stage the other lesions for another day. Then another type of angiogram we use here is called CO2 angiogram. This is an angiogram where we are not using contrast. We're just using CO2, basically. We're just injecting air. And I know it's kind of counterintuitive that we're always told don't inject air in the vessels, but this CO2, it's a certain machine that only injects CO2. And the problem with this test, it's painful. When you inject air into a vessel, the patients can feel pain for a few seconds. It's tolerable. I mean, we give patients some type of sedation, fentanyl or something, just to relieve the pain. But the good thing about it is if patients have allergy to contrast, some patients have also severe CKD and severe allergy that they really cannot tolerate contrast, even if you pre-treat them with steroids. And so we end up using CO2. I mean, CO2 is harder when you go below the knee, but we can still use it sometimes if we have to. So when you think someone has CLTI, the first thing to do is duplex ultrasound to identify where the disease is. And the next step is to do some type of imaging, MRI or CTA to know how bad the disease is, and also to help you plan for the procedure. And if ultrasound is only showing infrapopliteal disease, if the ultrasound is suggesting that it's only infrapopliteal disease, below knee disease only, I would proceed with angiogram right away rather than doing CTA and MRI, because I know CTA and MRI will be limited assessing such segments below the knee. This is kind of like the medical therapy for CLTI, similar to the PAD that we talked about last time. No smoking, no, statins, A1C less than 7, control blood pressure, ACE inhibitors, ARBs are the best agents. Rivaroxaban with aspirin, also the same thing. Cilostazol has no role in CLTI unless you're having rest pain. You might use it for just symptomatic pain relief, but it has no role in ulcerations and gangrene. And then the exercise training is similar to PAD. So just to review what we talked up to this point, we talked about the definition of CLTI, physical examination, hemodynamic criteria, the Wi-Fi scores, and the imaging modalities and medical management of CLTI. Now we need to talk about the staging system of CLTI, which helps us guiding the intervention, helps us decide what to do next. Should we just watch? Should we do surgery? Should we do endovascular? And I'll be talking about something called the GLASS staging system, which is a framework for classifying the pattern of arterial disease in CLTI. And the The glass, I like to think about it as like the syntax score for CAD. Successful revascularization in CLTI, especially patients who have ulcers, always require pulsatile flow to the foot. You have to restore the flow all the way down to the foot. It's not if you have diseases everywhere and you have tissue loss, you have ulcers or gangrene, it's not enough to fix just this lesion here in the femoral popliteal. You have to fix the whole thing. You have to make sure the blood is flowing all the way down to the foot. And the individual lesion schemes, such as the task score that we talked about last time, it correlates poorly with CLTI revascularization, because CLTI revascularization, it's a multi-level disease and below knee disease. And factors that determine a successful anatomic outcome are different for bypass than endovascular. Bypass requires you have to have good inflow and you have to good outflow when you do a bypass. And most importantly, you have to have a suitable graft. You have to have a venous graft, and we'll talk about that. The endovascular intervention depend on something called, we'll mention, well, I'll be saying it frequently, TAP, T-A-P, target arterial path. And you have to have inline flow to the foot. And that's what I mean by target arterial flow. You have to have a straight line of blood flowing from the aortic vessel down to the foot. And that's what I mean by TAP. And that's what endovascular success depends on. If you fix this lesion here and you leave all of this and you don't have good flow to the foot, we don't call this a successful endovascular intervention. You have to ensure that you have what we call TAP, target arterial path, all the way down to the foot. And so to apply or implement the glass staging system, you have to go through steps. We talked about imaging, and then we talked about identify the TAP. And we'll talk about it in the more details in the next slide. After identifying the TAP, you have to calculate the femoral popliteal grade and then the infrapopliteal grade, and then you come up with the final glass stage. And after the glass stage, you have to look at what we call pedal modifier. And we'll mention that also in detail to explain what that means. So glass is based on defining the TAP on each individual patient by doing a high quality imaging, as in this patient here. You need to select a preferred infrapopliteal vessel, and the TAP is selected based on the least diseased artery. So if in this patient, for example, there is disease in the 3 vessels below the knee, which one should you consider as the TAP? Which one should be considered as the target? And really, one way to look at it is you can select the least diseased vessel and try to fix that vessel. And another way to look at it is if there is an ulcer in a certain point, then maybe you have to select the vessel that supplies that ulcerated segment, and you consider that as the TAP. And that's what we mentioned earlier as angiosomal ischemia, or the angiosomal concept. Because again, in these patients with 3 vessel disease, you cannot fix all of them, especially at once. And so it's always wiser to just select one vessel and work on it. Now, looking at the femoral popliteal grading in the glass criteria. In the glass criteria, you have to look at the TAP, which vessel you need to work on, and then you have to look at the femoral popliteal and then infrapopliteal. The femoral popliteal from 0 to 4, it depends on the length of the SFA disease and also popliteal involvement. That's what the femoral-popliteal grading system depends on. If you have a short lesion in the SFA, that's grade 1. If you have a long SFA disease, that's grade 2. Or if you have a short CTO, or if you have a short popliteal, that's grade 2. And then grade 3 and 4, basically, the longer the lesion, the higher the grade. It's not, I'm not asking you to memorize these things because there are tools to help you, and I'll show you at the end how to calculate these things. But the concept is the femoral popliteal grading system depends on SFA and popliteal disease. And the longer the disease, the higher the grade. The concept for the infrapopliteal grading system, also from 0 to 4. It depends on how long the tibial disease is, and the longer the lesion or the presence of the CTO, then the higher the grade. Once we calculate the femoral popliteal grade and the infrapopliteal grade from 0 to 4, then we come with the glass staging. And the glass stage correlate with limb patency and technical failure in the future. And so the glass stages from 1 to 3. We have only 3 glass stages. The higher the stage, the worse the outcome. And so glass stages correlate, as I said, with limb patency and technical failure. If you have glass stage 1, then technical failure less than 10%. The patency chance in 1 year is more than 70%. And then if you have a glass stage 3, which is the worst, the chance that this vessel that you will work on will stay open in 1 year is less than 50%. So there is about at least 50% chance the vessel will close in 1 year if you work on it. And that's a very important information you as a physician need to know, and patients need to know as well before they commit to this procedure. And these tools are really helpful for us to bring these numbers to us and make it easy for us to understand the process, and also make it easier for us to explain it to our patients. And limb patency is a very important concept, allowing a more direct comparison between revascularization approaches in CLTI. And it means that the end line flow throughout the target arterial path or throughout the tap should remain patent from the SFA down to the foot. But if you have any restenosis in these segments that you worked on, or occlusion, or the ankle pressure index dropped after you intervened, or the toe pressure or toe brachial index dropped after you intervened, then that's considered a failure of intervention. Or if patients also develop rest pain again, or their ulcers don't heal, and they continue to have persistent ulcers, these are considered failures of interventions. This is an example of glass stage 1. The tap here is outlined in this yellow. This is the tap going from the SFA popliteal down to the anterior tibial. And the glass 1 here, because it's glass 1 because the femoral popliteal is 0, it's healthy, but the infrapopliteal, it has occlusion here. So that's infrapopliteal grade 2, and that's glass stage 1. Similarly here, there is SFA popliteal perineal. This is our tap, and the lesion is in the SFA. There is a long occlusion here. The infrapopliteal is healthy. So that's glass 1 because this is a femoral grade 2. Then we have glass stage 2 examples. This is two different examples. This patient has a tap of SFA popliteal and anterior tibial. And then there's an occlusion here, or lesion in the SFA to popliteal. and there is a short lesion in the anterior tibial here, and that's why this is a glass stage 2. The same thing here in the second example, SFA, popliteal, peroneal, and the SFA is healthy, but when you come at the peroneal, there is a long CTO here, long occlusion, and this is infrapopliteal grade 3, and that's why we called it glass stage 2. And then the last one is glass stage 3. This is an example of glass stage 3, and the tap here is involving SFA, popliteal, peroneal, and as you see here, there is diffuse disease in the SFA, almost occlusion here somewhere. Also, popliteal is involved in a disease here, and also the tibioperoneal trunk is involved, and the ostium and the proximal med segments of the peroneal vessel is severely diseased, and this is glass stage 3. So we talked about the femoropopliteal grading, infrapopliteal grading, and how we calculate the glass stage. Then there is something called the pedal modifier. The pedal modifier, it involves inframalleolar disease, any disease below the malleolus, and basically the vessels that supply the foot. And there are 3 modifiers. There is P0, P1, P2, and it really describes the status of the arteries that are crossing the ankle down to the pedal arch. And currently, these pedal modifiers are not part of the glass staging because there has not been enough research evidence to suggest how they correlate with the outcome, and that's why it's not part of the glass staging. But you have to understand, if you have a higher P score, then this patient is a very high risk. This patient is P2. There's complete loss of the vessels below the foot. While P1, there is one vessel supplying the foot, dorsal speed is but the posterior tibial is not. While P0, both vessels are still intact. And just this is kind of a review slide because these are heavy information, difficult information. I wanted to just summarize what I've talked about so far before I move to the next point about management. And so using the glass staging system involves these steps. You have to obtain, if you have a patient with CLTI, obtain images, obtain a good angiographic images. And we've talked about these limitations of CT, MRI, and then once we have images, we can define the tap. We can define which vessels we should be working on. The SFA and popliteal will be always involved, but then below the knee, which vessels should we work on? Anterior tibial or posterior tibial or peroneal? And then once we know the tap, then we have to grade the femoropopliteal segment. We have to grade the infrapopliteal segment, and then we have to do the glass staging. One thing we have to mention here when we talk about the glass stage is calcification. And so calcification, I mean by that is if you have a glass stage 1, for example, but the vessels are heavily calcified, that means there's more than 50% calcification in the lumen, then you have to increase the glass stage by 1. So the glass stage, it will go up from 1 to 2. Or if it was 2, it will become 3. But if it's 3, then it's 3. That's severe to begin with. After having the glass stage, then you have to look at the pedal modifier. Again, the pedal modifier does not give you an objective relation to the outcome. It's not involved in the staging itself, but it helps you define the revascularization strategy. Management of individual patients with CLTI. The first step involving assessing candidacy for limb salvage includes peri-procedural risk and also looking at the life expectancy of these patients. And so we have to look at the patient as an individual. CLTI is usually present in advanced age, multiple comorbidities, high frailty. And the goal of treatment of CLTI either includes either relieving rest pain if they have rest pain, or healing their wounds if they have ulcers, or preserving the functionality of their limb. They're still walking. You want to keep them walking, because once these people, older people, stop walking, then they go downhill. However, revascularization may cause significant morbidity and mortality. So revascularization itself is not free ticket. It requires multiple hospitalizations. You have to go to clinics, multiple visits before and after revascularization, and also a lot of cost on the patients and healthcare and social care. And so the majority of patients with CLTI should be considered for revascularization, but some patients may be appropriately treated with just amputation or palliative approach. Of course, after discussing with the patients and family and caregivers. If you decide to go through palliative approach, though, sometimes you still need to do revascularization. And this is a really important concept, is someone who is undergoing palliative approach, and you will do amputation, but sometimes you have to do revascularization for these patients to improve the likelihood of a successful amputation. So if you cut, if you do transmetatarsal amputation, you cut half of the foot, you need to make sure that the surgical wound will heal. And so if there is no good blood supply to the foot to begin with, you have to do revascularization before amputation, and then you do amputation, and then the wound will have a higher chance of healing because you did the revascularization before the amputation surgery. There are operative risk tools and life expectancy models that we use to really predict the risk of these patients. Age more than 75, diabetes, CKD, CAD, heart failure, history of strokes, dementia, functional status, frailty scores. All of these are part of your perioperative risk assessment for these patients. And the problem with these tools, they have been calculated or developed retrospectively. There is no strong prospective data about them. So there's really no preference of what tool to use for these patients, but you can use a tool such as the VQI score. The VQI tool, scoring tool, can be used for these patients before intervention. CLTI patients present with a broad spectrum of disease severity, and using the Wi-Fi score is also important. It's not just the GLASS score. The GLASS score will help you plan surgery, the technical planning, but the Wi-Fi score is still also important because it integrates the wound severity and ischemia and infection into the stage of the CLTI. And the benefit of revascularization in these patients is linked to both the severity of ischemia and the degree of limb threatening. The higher the ischemia, the more these patients benefit from revascularization. In the setting of advanced tissue loss or infection, the Wi-Fi stage 4, revascularization may be of benefit in the presence of moderate ischemia, such as here. If you have limb severity, infection or ulcer stage 4, and you have moderate ischemia, then you can do intervention or revascularization. There is a good benefit. But at the same time, if you have high ischemia grade, and this is from the Wi-Fi ischemia scoring, which is depending on the ABI or ankle brachial index and ankle pressure. If you have stage 3, then there is high benefit of intervention. But then there is a lot of in-betweeners. There are a lot of patients who might not benefit from revascularization, and you just consider wound care and medical therapy. And there is an intermediate part here where you have to look at the whole picture and discuss with patients the risk and benefit before you proceed with intervention or just wound care alone. Management of CLTI, the majority of CLTI patients are suitable for revascularization, and establishing what we called the inline flow to the foot is our primary goal. We have to open the blood supply all the way from the SFA down to the foot. But there are some exceptions to this rule. Patients who come in with ischemic wrist pain without ulcers, or patients who have very mild ulcer, Wi-Fi stage 1 ulceration, superficial ulcer, then you might just consider fixing the inflow part rather than fixing the inflow and outflow. And these patients a lot of times would feel better. So for example, if someone has multi-level disease, SFA, popliteal, anterior tibial disease, and they have just wrist pain, if you fix the femoral popliteal disease alone, that might be enough. And so this is an exception to the rule of you have to fix the whole line. There are patients who have no options. Those patients who have the P2 modifier, the patients who have no residual blood supply going below the malleolus. These patients a lot of times are considered no option. That being said, we evaluate the P2 modifier based on angiogram or CTA or MRA, but these tests sometimes fail to detect the distal artery bed. They fail to detect the vessel in the foot. And there are a few cases where, there would be successful bypass from into the tibial or pedal bypass after you open the skin and you explore the artery and you end up doing bypass in the foot. There is some success to this, despite there was no flow on the CTA, but this is an exception. That's not the rule. There are a few trials that were that involved CLTI. The first trial was the basal trial, was the first randomized trial. They were evaluating the effectiveness of surgery versus endovascular treatment. They involved about 450 patients who had infrainguinal disease in the SFA or below, and they had CLTI, and they were randomized to either surgery or endovascular approach. And the primary endpoint they were looking at is the time to major amputation or the time to death from the intervention. And the result was saying surgery was better than endovascular in only one way, which was the reintervention. Patients who had endovascular, they were more likely to undergo repeat procedures than bypass. but there was no difference in the amputation-free survival. And important to know that this is an old trial, and the limitation of this is the endovascular approach at that time. They only did balloon angioplasty. They did not do stenting or drug-coated balloons. Then came the BEST CLI trial, which was published in 2022 in the New England Journal of Medicine. They enrolled 1,800 patients with infrainguinal disease, and they divided them into two cohorts. One cohort will have great saphenous vein bypass versus endovascular, and the second cohort will have prosthetic bypass versus endovascular. So they divided them into two groups. They followed them for 2.5 years, and what they found is surgical bypass with great saphenous vein conduits had lower rate of reintervention than endovascular approach. But the amputation risk and mortality risk was similar. The prosthetic cohort had no difference to the endovascular group. The more recently published trial, Basel II, it was published last year. They randomized about 350 patients who had below-knee disease and had CLTI. They divided them into surgical, endovascular, and the primary endpoint was similar: the time to amputation or the time to death from the intervention. They followed them for 2 years. What they found here is interesting because it's opposite to what the older trial showed. The endovascular first strategy was shown to be superior to the surgery approach. And the surgery group, there was a higher rate of mortality in the vein bypass group. The mortality was 50% in the vascular group, in the bypass group, versus 45% in the endovascular group. Still, in this trial, the reintervention rate was higher in endovascular than bypass. So reintervention, if the patient's value is they don't want to come back to the hospital, and that's a big no for them, then endovascular is not the right option for them. So endovascular versus open surgical. There is something called in the US here, a lot of vascular centers, they advocate for what they call endovascular first approach, just like they say, radial first approach, these things first approach. It's kind of like advertisement. And so a lot of centers are saying endovascular first approach for most patients with CLTI. And they say reserving bypass surgery as a secondary option. The problem is that the current evidence in CLTI remains very limited. With whatever data we have so far from the previous trials, I mentioned mortality and amputation rates are similar for endovascular and bypass at 1 year, with improved patency for bypass if you use a venous graft versus if you use a prosthetic graft. So I think we have to follow a selective algorithm when we evaluate these patients based on their clinical factors, based on their anatomic factors, and we have to individualize plans for each patient according to their anatomy, perioperative risk tools that we talked about. Surgical bypass with prosthetic conduits to infrapopliteal targets in these patients in CLTI, they're not good. Patency rate for endovascular are not as good, especially in diffuse infrapopliteal disease. On the other hand, when we talk about surgical approach, we need to talk about the target for the bypass. An acceptable target for bypass surgery should provide adequate runoff to the lower limb and to the foot. So we need a continuous inline flow to the ankle and foot. The second thing we have to think about is the graft type. The good quality great saphenous vein is the optimal conduit for infrainguinal bypass surgery. Alternatively, you can use small saphenous vein or arm veins. They are acceptable, but there is higher risk of reintervention, and the durability is inferior to great saphenous vein. Also, you have to think about the techniques of bypass grafting. There's what we call in situ, and there's reversed, and there is non-reversed. These are techniques on how they harvest the venous graft. In the in situ, they just mobilize the end of the anastomosis while leaving the rest of the vein intact in the vascular bed. The reversed, just as the name is called, the whole vein is taken out and flipped upside down and anastomosed so that the flow can pass through the venous valves. And then the unreversed, the vein are taken out, the valves are destroyed, and then the grafts are sutured. There is really no strong evidence to support technique over another, but these are things you need to think about when you talk about bypass surgery. So treatment of common femoral artery and CLTI. In the CLTI, the common femoral is considered an inflow. Unlike in the other PAD, we consider the aortoiliac as inflow. And the first thing you need to remember is with CLTI, you have multi-level disease. You have inflow disease, you're going to have outflow disease. And so likely it will not be an isolated common femoral lesion. And the decision to perform staged versus multi-level revascularization for patients with combined inflow and outflow disease is individualized based on anatomic complexity, patient risk, kidney function. In the setting, as I mentioned again previously in the previous slides, if you have someone who has rest pain alone, no ulcers, you can just fix the inflow and see how they do. You can leave the outflow disease alone and see how they feel. The aortoiliac disease also may be treated endovascularly, and that's most of the approach now for aortoiliac is endovascular, using bare metal stents and covered stents. But for the common femoral artery, endarterectomy, surgical endarterectomy is mostly performed here with low morbidity and excellent durability. It remains I think the optimal approach for significant CFA disease. And sometimes we do hybrid approach. If someone has CFA disease and external iliac disease, then we do hybrid approach where the surgeon would do endarterectomy, and then we do endovascular treatment for the iliac disease. And you can also do direct anatomic bypass grafting from the aortic vessel to the femoral with good anatomic and hemodynamic durability. The endovascular treatment for SFA is not the first thing you think about. We don't do it as a first thing. It's a safe alternative in selective patients who are high risk for surgery or have hostile groin anatomy. Then we can do endovascular CFA treatment. We try to balloon and modify the plaque and open the vessel without putting a stent in this CFA if we can. Below the knee in the SFA, this table provides a summary of preferred infrainguinal revascularization strategies for a patient who is average risk and has available vein graft conduit. And based on the Wi-Fi stage and based on the glass stage, you can decide what approach to do. If you have a patient with glass 3 here and limb severity is high, then open surgery is the preferred method. But if you have someone with glass 3 with glass 1, then endovascular usually is better. And remember, the glass 1 usually involves these lesions that are shorter. Glass 3 involves lesions that are really long with long CTOs. For patients with no venous conduit, you have to think about these patients differently. If you don't have a good venous conduit, you might want to consider endovascular intervention in most of these patients rather than a prosthetic conduit bypass surgery. If you want to do a prosthetic endovascular bypass, you have to have really good runoff, and patients should be able to tolerate antithrombotic therapy. Now, this table talks about average risk patients, not high risk patients. So the average risk patients, it really is defined by the peri-procedural risk, and this is based on the tools that we use for peri-procedural risk. If the risk of the peri-procedural mortality is less than 50%, that's an average risk. But if it's more than 50%, that's a high risk. So high-risk patients, you need to think about them differently. High-risk patients, we tend to do more endovascular than open surgery because of the morbidity associated with surgery. And of course, a lot of these you have to do a shared decision making with patients and caregivers and families before. And also, it's a multidisciplinary. You have to discuss with your colleagues from surgery and from endovascular to decide what to do. Inframalleolar treatment in CLTI. If you have CLTI and there is severe disease in the foot vessels, this is very challenging, especially with someone who has P2. All of these vessels are gone. The pedal arch is gone. And so there's no suitable target for bypass surgery. And endovascular approach in the pedal arch also is not easy. It can be sometimes successful, but their durability is unknown. And the same thing for bypass. It can be done. You can connect these vessels to small plantar arteries or tarsal arteries, but again, the outcomes are not well established. So, given the technical the difficulties in these patients and likely these vessels will close again, you have to think about these patients differently, and the appropriate method of intervention in these patients is not really clear. Endovascular, in endovascular, balloon angioplasty remains the primary approach, especially for below knee disease. Now we have other tools. The balloon angioplasty is not as good as drug-coated balloons anymore, and we have stents for treatment of femoropopliteal disease, but we don't use stents in the infrapopliteal yet, but we use drug-coated balloon. That being said, there has been a lot of technical advances in the endovascular field, including, we have better wires nowadays, we have better catheters, and we have shock waves and better stents, drug-eluting, drug-coated balloons. And there is something called also the scaffolds, the bioabsorbable scaffolds that I will mention here shortly. So we can first talk about balloons. As I said, ballooning with regular balloon is the standard of care for endovascular treatment for below knee. The patency rate for intervention is around at 1 year is about 50 to 60%. So not great. Sometimes it can be as high as 70%. How do balloons work? So when you have a calcified or fibrotic atherosclerotic plaque, like in this picture, when you inflate the balloon, the plaque will not get thinner and will not get compressed. That's not what happens with ballooning. What happens is when you inflate the balloon here, this fibrotic or calcified plaque will get pushed outward, and the vessel will stretch, and it pushes the plaque outside, as you see here. And so the plaque has moved into the outside. And at the same time, it can cause, dissections in the plaque, and sometimes it can cause dissections even in the healthy segments above and below the lesions. And so the problem we face when we use balloon angioplasty is dissections. Another problem we face is something called dog boning. This is bones that dogs use to play with or eat. And so that's what we call dog boning. You can imagine if you have a heavily calcified and fibrotic lesion here, and you inflate the balloon, and you have, especially if it's a longer balloon, this part of the balloon, distal, and the proximal part of the balloon will inflate faster than the central part of the balloon. And that is what we call dog boning. And this dog boning phenomena can cause dissections at the edge of the lesions, and even in segments that were healthy before. And you can see here in OCT these dissection planes that we have caused by ballooning. And the reason is when you inflate a balloon in an atherosclerotic plaque, there's really no place for that plaque to go except to dissect. And when you have dissections below the knee, it's a problem because you have to cover these dissections a lot of times, and you end up using stents in small vessels, and that's not a good thing. And so bottom line, if there are heavily calcified lesions and not expanding with balloons, you should not go very high on the balloon inflation because that can cause more dissections. You just need to think about something else that minimizes dissection and minimizes recoil. And the solution for minimizing dissection is and when we deal with these calcified and fibrotic lesions, is something called specialty balloons. There are a few specialty balloons that we have available in the peripheral world in the US, and the goal is to inflate at lower pressure so that we prevent dog boning. And the intention of these balloons is to prevent dog boning in the healthy segments, and they're more helpful in below knee disease. There are a number of these balloons. We have Angiosculpt, which is a non-compliant balloon that has external nitinol wires, and these wires kind of score the plaque, avoiding slippage of the balloon, and offers controlled, predictable dilation of the balloon. Another balloon is called the Cernator balloon, which has serrated strips here embedded in the balloon, and that creates controlled and even this distribution of pressures, cracking the plaque and achieving greater vessel compliance at lower balloon pressure. And then we have the chocolate balloon, which is basically a compliant, semi-compliant balloon that has nitinol wires throughout the balloon, almost forming a cage. And this cage confines the balloon, prevents it from slipping, also prevents dog boning. And so the whole balloon will inflate equally. And ends up inflating the plaque at the same rate as inflating the other healthy segment. Then we have the Wolverine balloon. It has it's also one of the cutting balloons. It has kind of like microsurgical atherotomes that anchor to tissues and precisely dilate calcified lesions at low pressures. Along the line with the specialty balloon, when we cause vascular injury with ballooning, whether we use balloons or scoring balloons, the nature of the vessel will tend to restore and restenose. And one of the mechanism of restenosing of these vessels after ballooning is smooth muscle proliferation. And so we want to utilize an anti-proliferative drug to alleviate this mechanism. And that's why we use the drug-coated balloons. We have the Impact, we have the Ranger, Stellarax, Alluvia, Zilver. If you remember, we talked about them in detail last lecture. These are the drug-coated balloons that we have currently, and these balloons have anti-proliferative drugs on the surface of them, and it prevents the smooth muscle proliferation. The current peripheral drug-coated balloons we have are piclotaxel family, and they work on the cytotoxyl cycle, and specifically the G2 phase. There is a bunch of plaque modification techniques and tools. Everybody uses different things. There's really no criteria, no guidelines what to use what. We use them selectively based on lesion morphology. They are really adjunctive therapies. I divide them into 4 major types: directional atherectomy, IVL, lithotripsy, orbital or rotational atherectomy, and ablative atherectomy. It's really important to match your atherectomy device to your lesion. Typically, you would pick the device based on the degree of calcium in the lesion. Here you can see in the left panel, very heavy calcium throughout the patient, the SFA. And the wire is sitting in the profunda here. Now you can see the calcium has caused a CTO in the SFA, and then moderate diffuse disease in the SFA. So there's a CTO here, and then moderate diffuse disease. And crossing intraluminally in the true lumen is very important if you plan to use atherectomy device. And you can confirm that with IVUS or intravascular ultrasound before you do atherectomy. So what type of atherectomy device to use will depend on how much calcium, and if there's CTO, and if you are instant restenosis, if you are intralumen. And the other point is you always use embolic protection devices, especially in the SFA and popliteal. It becomes harder to use embolic protection devices in the tibials because the tibials are smaller vessels, and the embolic protection devices are large. But you can prevent the no reflow phenomena by doing vasodilators. We use significant amount of nitroglycerin with peripheral interventions. Unlike coronary interventions, the coronary intervention, you give nitro, you develop hypotension. It's much more tolerated with peripheral than coronary, and also we use adenosine. So when to apply which device? This is sort of a working algorithm. If there is a soft plaque, do directional atherectomy. If you have heavy calcium, do shockwave or lithotripsy. If you have a mix, if you have in-stent restenosis, do orbital or rotational. And if you have heavy thrombus inside the stent, do laser atherectomy. Talking about stents for peripheral, for CLTI, there was prior studies saying stents are harmful for CLTI. This study was published in 2019 in JACC, and it showed that CLTI, if you do stenting, it's not harmful, although it's not better than bare metal stents. So there was no difference between bare metal stents and drug-coated balloons in peripheral. Another trial, the SAVIL trial, published in 2023, looking at drug-eluting stents versus ballooning in infrapopliteal below-knee interventions. And basically, the trial showed that stents are not better than ballooning. The primary endpoint at 1 year was similar, and actually maybe better in the ballooning, a little bit better in the ballooning than stents. And the safety endpoint was similar for both ballooning and stenting. So below-knee intervention, we don't do bare metal stent, we don't do drug-eluting stent. But this trial came and it was published this year in the New England Journal of Medicine. It's called the Live Below the Knee Trial, or Live BTK trial. And they looked at the safety and efficacy of scaffold, resorbable scaffold, compared to balloon angioplasty in below-knee intervention. And resorbable scaffolds, they're really a very attractive alternative concept for below-knee intervention. They provide mechanical scaffold. They're just like a stent, metallic. They're similar to metallic stents, and they are also coated with drugs, just like drug-coated stent or drug-eluting stents. They are coated with anti-proliferative drugs. But the difference between them and drug-eluting stents is they get reabsorbed by the body slowly with time. It takes a few months for the stent to get reabsorbed completely, and ultimately the whole stent disappears. The only thing you can see in the future, if you do fluoroscopy, you can see these small platinum markers, two here, two at the other end. They're very hard to see, but there are these small markers that you can see, but the whole scaffold will disappear in a few months. And so in this trial, they involved 260 patients. They were randomized 2-to-1, and they were followed for 1 year and randomized to regular ballooning versus scaffolds for below-knee intervention, specifically in CLTI. And this is the primary endpoint. 75% of patients with the scaffolds versus 50% in the ballooning. So the primary patency at 1 year and amputation risk was much better with scaffolds versus below the knee ballooning. Very important question here we need to ask ourselves when we treat patients with CLTI, especially when they have Glass 3 and they have a P2 modifier inframallular and the patency rate is low. What do we do in this case? If you have someone who has wounds, they have no rest pain, and you just want the wounds to heal, a lot of times you would just intervene, you do revascularization here, and when you do the revascularization, you improve the patency until until the wound heals. And then even if the patency drops down, still the wound would have healed. And so you achieved the goal basically by helping the wound to heal with the intervention. And we do that sometimes with patients who have very diffuse disease and there's really no surgical option for them. There's no good and endovascular option. We just go in, wire, balloon, and restore blood supply to the ulcerated area for a few months, let the wound heal, and then it might close again, but the wound have healed, and that's the main goal. Post revascularization management, you have always follow these patients with non-invasive management, ankle brachial index, toe brachial index. Medical therapy is really important. Wound care is very, very critical, very important. It requires specialized wound care teams, podiatrists, foot doctors, and it's a big topic, and we can talk about it in the future. In summary, CLTI as bad prognosis. The main goal in CLTI is to restore blood supply to the foot. Open surgical and endovascular approach are probably similar. We need substantially more perfusion to heal a wound than we need to keep it healed. And that was the concept when I said we have to open the vessel just to let the wound heal, because we need a lot of perfusion for wound healing, and almost higher than 20 millimeter mercury of toe pressure than you need to keep the wound healing. There are better technologies showing up for baloney interventions, scaffolds, and drug-coated balloons. And so that field is really getting better. Ischemic ulceration heals at a rate of 1 centimeter per month, and so that larger ulcers require durable procedures. That's something you have to keep in mind when you are trying to intervene in these patients, whether they have a large ulcer, whether they have a small ulcer, what's the size, how many months it will take for the ulcer to heal. Finally, CLTI is a multidisciplinary field, as I mentioned. You cannot do it without endovascular interventionalists, vascular surgeons, wound care specialists, podiatrists, nurses, family support. These are important references. I sent them to you before, and this is the SVS, and it's an app on the phone, and I'm going to try to open it from the phone just to show you how this app looks. And it's a very good app. That's why I was telling you, you don't have to memorize the glass score. So if you look at the SVS, this is the SVS app. And sorry. So the SVS app, when you open it, you'll have let me just open it again. So this is what the app looks like. CLTI management. I think you can review the guidelines here. You can do clinical decision-making tool, CLTI management, and then if you click the CLTI management, you can go to the glass staging system. You can go to the Wi-Fi staging system. And so, and also you can use the peri-procedural risk prediction model. Like if you do this example here, what's the stenosis is there stenosis in the femoral popliteal? Is there CTO, short CTO? And then is there popliteal disease? For example, there's stenosis shorter than 2 centimeters. Is there heavy calcification? You can say yes, there is heavy calcification. And then you look at the infrapopliteal. What's the preferred tab? What vessel will you use below the knee? Are you going to use PT, peroneal? And then you assess that vessel that you will be working on. And these are just random examples just to show you how it's going to look at the end. Um, um, and then is there heavy calcification? And then you can calculate, and this is what's going to show you. Glass classification, femoral popliteal grade 3, infrapopliteal grade 3, glass stage 3, high complexity risk. The same thing for the Wi-Fi. Is there ulcer, gangrene, infection? And so, if there's small shallow ulcer, is there gangrene? What's the ischemia? You have to, we talked about the toe brachial, the toe pressure, usually less than 40 for CLTI, and severity of infection. Then you can calculate, and this is what will show you Wi-Fi 1 to 2, clinical stage 4, amputation risk is high, and potential benefit of revascularization is high. Very important information. It helps you plan before you talk to your patients, and also helps you show the patients. You can show the patients these things too. Share with them how you are coming up with these decisions. And then you can talk about the mortality prediction model above 80, for example, white, an indication for tissue loss. And anyways, a lot of things it can show you here. And I'll just finish this example quickly to show you how it's going to look at the end. It looks at CHF, COPD, and CAD, and all these things. And then it kind of gives you you have to answer all the questions here. CKD, what the GFR is, and then you can calculate. And so high risk, estimated 30-day survival, 90%, estimated 2-year survival, 40%. These are really important numbers, and we always, human beings like numbers. Patients like to hear that my risk of this procedure, if I do it, is this percent. If I don't do it, is this percent. They don't like saying, oh, this is better for you, this is not better for you. They like to hear numbers. And so I think this is a very helpful tool, and it's mostly used for CLTI. Any questions? I think we're done here, and I'll share the screen here again. All right, happy to receive any questions. If you have any.
ثانك يو يا دكتور أنس، ربنا يجزيك الخير. حقيقة great talk, definition, classification, what it is زي ما يقول. الحقيقة الكونكلوجن أنا يعني ما كان زي التوك اللي كان إنه الاندوفاسكولار similar like surgery كان نمبر 3 الكونكلوجن اللي عندك. ومع انك ذكرت انه في البازيل ترايل والبيس ترايل سواء كانت الاول او النمبر 2 انه الري انترفنشن في الاندوفاسكولار اكثر. وانا I want to stress على هذه النقطه ان many people يمكن يموت عادي. might he die عادي. To get amputation is the normal. But to have a reintervention is a disaster. اليوم بس اليوم مريض قبل سنة ونص كان خلينا نقول واي فاي كلاس 3 وكلاس 3 وحط كان ريست بين ما ينامش. هو عملنا له فيم جرافت لأنه كان عنده ريسك فاكتور، حتى بنرجع الملف حقه. بعدين فيم بوبليتيال وجلس سنة ونص فاين وبيرفكت، ورجع الريست بين بعد سنة ونص. and he was going and complain على المجلس الطبي. وصلتنا ورقة، ما عندنا مجلس بس تفاجأت انه صار مجلس في تعز. فقلت لهم عجيبة والله، مع ان تذاكرنا 50%. تعرف ايش كان الري انترفنشن؟ لانه طلع صنعاء وقالوا له وانت اوبن بالاندوفاسكولار، فخلاص صارت عنده هذه واي تيوري اوبن بالاندو، وليش عملوه ليش مرتين. ف
وصلتكم
in
ورقة
Yemen
من
is not
وين؟
similar. خذوا ورقة وصلت لهم المجلس الطبي، صار عندنا مجلس طبي. تفاجأت انه في شكوى على الجراحين اللي عملوا العملية ومنتظرين الرد. ليش بعد سنة ونصف يحتاج ري انترفنشن؟ حتى المجلس الطبي ما هوش فاهم تفاصيل الشيء. يعني المفروض انه يجاوبه هو اوتوماتيك ويقول له انه هذه كرونيك لمب اسكيميا او سي ال تي اي اللي تقول ثيرتينينج لمب اسكيميا. اتس جود. وانه السكسس ريت على 3 years اذا يو اتشيفد ال 50 از اتشيفمنت. هذه اول نقطة. النقطة الثانية، الحقيقة أنا حاب أسألك يعني باعتبارك ممارس لهذا الشيء وهو غير موجود في اليمن، هل الترايلز هذه كجريد وثقت نفس الجريد في السيرجري، نفس الجريد بالريسكي في الاندوفاسكولار؟ لأنه أنا زي ما ذكرت أنت بالسلايدز حق الكومبينيشن الجلاس مع الواي اف اي، انه الاثنين مع بعض اذا كانوا 3 3 فهي خضراء خضراء سيرجري. بالتالي he will not go for endovascular unless he is rejected by surgeon.
So
معروفة لازال if it is complex this أنا شايف لي this syntax trial بيكون آخر سؤال ثالث لي. شوف صراحة أنا حافظ أشياء، نحن سيرجن في الأخير ونحفظها كذا سطر سطرين وما نعرف نحفظ زيكم الكارديولوجيست. يعني مثلا حافظ السيرجري عندنا هاي سنتكس سكور 3 فيزلز ديابيتك لو اي اف you should go surgery كلاس 1 كلاس 1 كلاس 1. في زي كذا مبسطة بالاندو بالبريفرال. هذا السؤال الثاني مع خالص الصحيح صراحة رائعة ورح راجعها ثاني وثالث ورابع.
yeah, I mean, for the الأشياء اللي بتحصل مع patients, the conclusion to begin with, as I said, the amputation and mortality risks were similar, but the reintervention was clearly higher in the endovascular. And that's what, when I said in the conclusion, surgery is probably similar to endovascular, because the patient's values here are different than back in Yemen. Patients here care about easier things, less invasive things. They don't worry about money, the insurance is covering. And so if they find an option that will help them get better, even if they know there is a chance for coming back for reintervention, a lot of them would still accept the endovascular approach. النقطة بنفس الموضوع هذا، يعني شيء مؤسف جدا انه صار زي الكالتشر في اليمن، انه المرضى صاروا يشتكوا بالاطباء. عشان كذا these risk models، يعني احنا بنعرض هذه الارقام وهذا الدسكشن مع المرضى هنا. And we tell them, there's this and this amount of risk if we do this procedure. And they know exactly, and that's what they call informed consent. They consent after being informed in details what the risks are. Even if patients die, they already know, and the family accept that because we told them. I mean, there's no فشي مؤسف في اليمن انه هذا صار زي الكلتشر، المجلس الطبي كل من حصل شيء يروح يشتكي. يعني that's nonsense. The other point about the trials, they really did not specify the when they randomized these patients, what they did not randomize them based on their Wi-Fi score or glass stage. They just randomized them because they have CLTI based on the definition of having hemodynamic compromise with rest pain or ulcerations. And then they study this afterwards, and they find that, both groups had similar Wi-Fi stages, similar glass stages. So there is no difference in the Wi-Fi and glass stages in these trials. They're almost the same. The third question is, I don't know of any easy way. I mean, again, these detailed tools that we use, I'll tell you, when you are practicing in the field, you don't really base your decision. You don't make your decision based on these tools before you talk to the patient, but you like to have these tools available for you to present to the patient. Because as a physician, in your experience, after seeing the images, you already know that based on my experience, based on all these cases I've done, I think the best approach would be, I think, endovascular. But you don't have numbers, objective numbers, to tell the patient why you said that decision.